while the samples are being processed for in your coagulation lab. So this is about finding errors before you start processing the samples. Just remember that thing. What you have to do is take up a good history. Whenever a sample is received in a coagulation lab, you should have that performer with you, what all things can be wrong at the physician end when you are accepting the samples, when you're processing the samples, and also when you are interpreting the results of those samples. Okay, so just correct me. We have Dr. Neha, Dr. Marina, and Dr. Abhijit only as discussants. Am I correct? Or any other discussant are there?
Dr. Abhijit, Dr. Marina, Dr. Neha, Dr. Shukla Diksha, and Abhishek. Abhishek is here.
No, I think Dr. Supriya is there.
So Dr.
Dr.
Supriya,
Yes, sir.
she is not.
Yes, sir.
She's not introduced herself.
I am Dr. Supriya Upriti, studying in Nova Medical College as a second-year resident in Department of Pathology.
hi doctors. So as we go along this talk, what we'll discuss are what are the various issues in the coagulation lab. So like I said, this will be based on the pre-analytical variables. So pre-analytical means there are three stages of any test which we perform. The analytical part is the thing which is done in the lab where the actual test is performed. Pre-analytical is everything which is after that, which is prior to that processing in the machine. So this could be from the time of a patient coming for sample or in the ward to the sample being taken, sample being transported to the lab, received in the lab, then finally the sample is processed. That is the analytical part. And the post-analytical part is when the sample result is out and you want to validate or finalize that report and share that report with your clinician friend. So the chain starts with the patient and the clinician. The test is done in the lab. The report is interpreted by the pathologist concerned and given back to the patient and the clinician. So that's how the chain, complete chain goes on. So is there any confusion? So can you guess any of the participants? Maybe you can start with Dr. Supriya only. So Dr. Supriya, can you guess what is, how common are these pre-analytical variables or errors which lead to issues in a coagulation lab because of pre-analytical variables?
So there are about 1/3 to 3/4 of error due to the pre-analytical variables. The common.
What do you mean by that? So if there are 100 errors, 100 problems which occur in a coagulation lab with a particular error, 100 with a particular sample, that means almost half of them or almost 50-60% of them can be because of the various pre-analytical variables which can interfere with the interpretation of that sample. Okay, so errors can be multifold. What we'll do over next around 9-10 slides is discuss what all things can go wrong and at what variables. So Dr. Neha, at your hospital, what all coagulation tests are you performing?
Sir, prothrombin time, APTT, sir, D-dimer, sir, these things are performed here.
Okay. Do you do factor assays?
Sir, no, I don't think, sir. Factor assays are not performed.
Any other students whose lab perform factor assay? Okay, so just try to always include platelet count in your coagulation lab. That is.
Pardon, sir. Sir,
I
think
we can't see your screen.
You have stopped sharing, sir.
Oh, don't tell me.
Yes, sir.
Yeah. So always include platelet count as a part of your
Sir,
coagulation.
your slides are also not moving, sir. Can you just
I'm still on the first. Does it move now? Are the slides moving now? Yes, no?
Yeah, right. Yeah.
Yes, sir.
Yeah, so that's okay. So always include, platelet count in your as a part of your coagulation lab, and whenever you are interpreting various reports, try to have an idea about platelet count as well. So we start with Dr. Marina about the various patient-related factors, that is, the patient factors which come into play before the sample is collected. This is just some of the brief things which are important for the sake of a discussion, and just introduce these things. So patient should be in a nice supine posture, stress-free, not have done exercise recently. Pregnancy is a physiological state, can be associated with hypercoagulability. So there is a very balanced kind of a thing with respect to coagulation and bleeding, which goes on in pregnancy. Various drugs which the patients can be on, like warfarin, heparin, DOACs like rivaroxaban, apixaban, or dabigatran, and high hematocrit, that is high hemoglobin, where it can have an impact on the various coagulation assays. So, Dr. Marina, let's discuss all these factors one by one. So, why do you think the history of pregnancy is important while interpreting results in a coagulation lab? Hello?
Yes, sir.
So, why do you think the history of pregnancy, or let's say other physiological states, like a newborn child or elderly patient, these are important in a coagulation lab?
Sir, in and there is dilutional due to increased plasma volume, so fall hemoglobin will be less. So many factors that affect the result actually. And in case of newborn, there is increased hematocrit in this.
Your voice is breaking, doctor. Is it with me or hello?
Sir, hello, sir.
Yeah, yeah. So pregnancy, you
So
told about dilutional thing, and what about the newborn?
uh, increased MCV. There is increased hematocrit.
Yes. And anything else?
Mm,
So one of the other thing which happens in the newborn child is that the amount of blood which is to be collected is important, especially if you give a routine citrate vial for your patients. So almost all the tests in the coagulation lab are collected in a citrate vial. We'll discuss about that also. So that in that the ratio of blood to citrate should be in the ratio in the 9:1 kind of a ratio is required. So if you have a fixed vial for all the patients in the hospital, for a newborn child to collect that amount of blood can be problematic at times. Okay.
yes.
And to collect that blood, that amount of blood, many a times for the newborn samples, or let's say even during the first couple of years, the pediatrician or the sample collection person might be squeezing the hand or the limb to get that required amount of blood. This will, what that does is, is activate the coagulation pathway then and there. It also lead to dilutional things, and what you get is not the representative sample from the patient. So that can lead to various abnormalities in the interpretation of the coagulation assays. Plus, for the newborn period, at least the values of your coagulation test can be different as that from the adult. So that much variability and that records are to be kept in mind. So the age of the patient becomes very important at that time. Uh, any other disease state can you think of where the coagulation assays are to be interpreted carefully? Dr.
Sir,
Abhijit, can you think
uh,
of any other disease state where Coagulation assays has to be interpreted very carefully.
Sir, if there is an autoimmune disease or if there is any
Like,
infection, underlying infection,
okay, which infection like?
like in HIV, sir.
Okay, why, how come HIV leads to alteration in the coagulation pathway?
Sir, like
So not necessarily. Yes, some of the infection can activate coagulation pathway and can lead to DIC kind of a state, especially if the patients are in a very septic kind of a situation. There, your coagulation pathway might be hyperactive and can lead to a DIC kind of a state. But otherwise, if you think of various disease states, like you can have a patient with uremia or a bad, very much deranged kidney functions, and obviously, if there is a severe liver disease where the production of all the clotting factors is deranged, so that can have a physiologically changed norms of area all the coagulation assays. So the history of liver disease is very important in any coagulation disorder. Whenever you are interpreting the results, so whenever you get a sample from the medicine ward, sometimes from the pediatric ward, and definitely from your hepatology colleagues or gastroenterology colleagues, just just be careful that you have the history of liver disease is not there, and especially if you have unexplained prolongation of PT, uh, try to look at the patient's liver profile before you sign out the report, or have a just that kind of report that correlate with the liver history if the patient is having any liver disease or not. Okay, so I've enlisted some of the drugs. These are various anticoagulations, anticoagulant like warfarin, vitamin K antagonist, heparin, which acts by inhibition of antithrombin, DOACs, which act by inhibition of factor 2 or factor 10. So all these agents can lead to variability of the PT and APTT. So the history of any of these drugs, if the patient is on any of them, that is to be taken care of. And many a times you will be receiving patient sample for warfarin monitoring. Warfarin monitoring is done with INR. So therapeutic INR is between 2 to 3. uh, that means if your lab is not reporting INR, that means PT will be prolonged in all these patients. Similarly, any kind of heparin, APTT will be prolonged, especially unfractionated heparins, which might be given to neonates or patients on central line. Nowadays, most commonly, DOACs are given as anticoagulant of choice, and they can lead to variable interference in PT and APTT. Last case scenario is about high hematocrit. This is a very interesting kind of a phenomena. Uh, Dr. Supriya, can you think of various situations where the patient can have high hematocrit or high hemoglobin? Can you think of some situation where the patient can have high hemoglobin, high hematocrit?
So mostly in patient with dehydration,
Okay, good.
even in burns,
Newborns is good.
or if the patient has polycythemia.
Very good. Polycythemia vera can be a condition. Good.
Uh,
The other conditions can be when the patients are residing at high altitude, where physiologically their hemoglobin and hematocrit can be very high. Then your patients from cardiothoracic ward or cardiology wards, where patients of cyanotic heart disease, they can have a very high hemoglobin. Okay. Many a time their hemoglobin can be above 20. That means their hematocrit can be above 60 in such scenarios. What happens in that case? Can you guess, Dr. Supriya, what happens in such a scenario when the hematocrit is very high?
so in relation to coagulation factor, or
Yes. In relation to coagulation.
if uh, uh, if hematocrit is very high, then there is false prolongation of coagulation profile.
Why does it occur?
Um,
So what happens is when you have very high hematocrit, that means the plasma volume goes down. Okay.
Yeah.
And as a result, the amount of plasma with respect to the citrate in the coagulation vial which you send, that the citrate vial which you send, that becomes less. What happens in such a scenario is you will have a relative excess of citrate, your anticoagulant in the sample, as compared to the plasma which is there. Okay,
Yes.
समझ आया?
Yes, sir.
So most of our samples, most of the vials, they are tired to cater to samples where hematocrit is somewhere between 40 to 50. That means hemoglobin of around 12 to 15 or 12 to 16. Okay, that is the normal hemoglobin range or the normal hematocrit range, that is 40 to somewhere between 40 to 50. For less hemoglobin, it can cater well, but if the hemoglobin goes very high, the amount of plasma decreases, the percentage of plasma decreases. As a result, whenever you are taking the sample, the citrate is in excess, and that can give you a false result because citrate is an anticoagulant like all these drugs. Okay. So the clotting, the mechanism with which you are testing the sample, that will not happen in a very correct way. Okay. So we move to the next slide. So, okay. So these are some of the errors which can happen during the venipuncture. Dr. Neha, I'll discuss these problems with you. So first is about, prolongation. Whenever you take a sample, many a times, tie the tourniquet very tightly. In such a scenario, hemoconcentration can occur. I discussed already that heparin contamination can occur when the sample is being taken from central lines or PIC lines. Sometimes, and this is not very uncommon, but these things scenarios have happened, that there might be underfilling of the sample or a wrong tube being taken. You took the sample in let's say a plain vial or a EDTA vial and then put it in the citrate vial. All those things have happened earlier. So all those errors can happen in the lab, in the collection kind of time. So during the venipuncture, it is important to ensure that the tourniquet is not very tightly and very prolongedly done. This is important. So Dr. Neha, can you highlight where all can you get heparin contamination?
Sir, um,
In what
okay,
scenarios
sir.
do you suspect heparin contamination?
No, I don't. Um,
Huh? Just think of a scenario when a sample is being taken from an IV line and the patient is being given heparin for some reason or the other. So from which ward do you
Yes,
expect that heparin contamination might occur?
uh, sir, if we draw blood from heparinized lines like sir, central venous catheter or
Very good.
arterial lines,
Very good.
sir, or sir, maybe if IV cannula, if it is um, um, flushed with heparin, then maybe it's, from that only.
So usually IV cannulas are not flushed with heparin. It is the central
Yes,
lines
sir.
which are being flushed with heparins, or sometimes for arterial lines, some amount of heparin might be taken as fluid to keep the line
Yes,
patent.
sir.
Uh, when will you, let's say, in what kind of patient will you suspect this thing?
Sir, sir, we want patient who are on heparin therapy, sir. And
So what kind of patient are likely to have, let's say, central line or PIC line in a CVAD devices put in them?
sir, in central line, sir, burns patients, sir.
Okay, good.
Uh, um, and sir,
Think. In what wards are central line most commonly put? So central lines are most commonly put in sick patients. We agree?
Yes, sir.
So where do you find sick patients? In ICU kind of settings.
Yes, sir. I see.
Okay. In post-op
Yes,
settings.
yes, sir.
Okay. Many a times in your oncology patients and especially hemato-oncology patients who are put on central venous access devices for not for giving not during their for their chemotherapy and other administration. So many a time these patients are put on central lines, especially leukemia patient, they are put on central lines. So these can be central line, can be the neck line or the PICC line or various kind of catheters are there, but uh, it is kind of customary and mandatory to keep the line patent after any kind of usage. That line is either flushed with normal saline or with a heparinized saline. Okay, so that keeps the line patient. Otherwise, the line will get blocked whenever whenever a sample is drawn from the line or blood is given to the line or any other kind of drugs are given to the line. So to keep the line patient, the lines are flushed with around 5 ml of heparinized fluid or normal saline. So that is why whenever you have a patient sample coming from ICU, coming from a hematology ward, coming from an oncology ward, even neonatal ICUs or pediatric ICUs for that matter, just be wary. If the patient is showing a prolonged APTT, carefully interpret that whether the patient was, just ask your clinical colleague whether the patient was on heparin or not. So this becomes a very important kind of a thing to rule out in such a scenario. Uh, Dr. Marina, can you tell me which of the coagulation assays is very, very sensitive to heparin contamination? So it's thrombin time, it's very sensitive to heparin contamination and is invariably prolonged. Yeah. And
APTT, sir, activated partial thromboplastin time.
so APTT will be prolonged, but APTT can be prolonged in some other condition also. So thrombin time is your test when any kind of even minor kind of heparin contamination in which it will be very much prolonged. Okay. So
Okay, sir.
let's move to the third. So we discussed about this thing. The anticoagulant use is 3.2% trisodium citrate. You have to maintain a 9:1 ratio for blood to citrate. Uh, these are two important scenarios: underfilling or overfilling of the tube and the high hematocrit. High hematocrit we have discussed various scenarios where what can occur. So how can you correct for this thing? Dr. Marina, how will you correct? How will you adjust the citrate volume if the patient has high hematocrit?
Sir, their ratio is applied, formula is applied to correct the citrate ratio.
So
Volume.
one thing, you can do two things in such a scenario. Either you use that formula, okay,
Yes.
it's a very complex kind of a formula.
Um,
Other thing is, if you are preparing the vials at your center, you can use a lesser amount of citrate and mark the tube to give the requisite amount of blood. Uh, how will you correct underfilling or overfilling of the tube, Dr. Marina?
yes.
So underfilling of the tube will have the same effect as high hematocrit. Underfilling tube will mean the citrate will be higher. Okay.
Yes, sir.
All your coagulation or all the tubes which we have, there is a black mark up to which the tube is to be filled always. So if there is an underfilled tube, that means the amount of blood is less. That means the proportion of citrate will be higher. Can you do anything about such a sample?
Sir, recollect the sample.
No. Unfortunately, nothing can be done for such a sample. You have to reject that sample.
Yes, sir.
Okay. So recollection, when you're recollect in a fresh tube. That's an easier thing to do, isn't it?
Yes.
That's a easier and more obvious thing to do. Just send the repeat sample. It's more easier to communicate that thing to the ward rather than sending that half-filled tube back and having it again. Okay. So these things are important. So when you have an underfilled tube or when the patient has a high hematocrit, like in the various conditions we discussed, so correct the citrate volume is the problem here, and these things can be sometimes corrected, but most of the time you need to have a fresh sample. Okay. Uh, sure. So, Dr. Abhijit, this is not a very infrequent kind of a mistake which occurs when the resident or the person collecting the sample has just taken up the sample, not mixed the sample well, and that has led to a clot formation in the sample, or he or she has mixed the sample very vigorously. This can lead to hemolysis. Okay, and occasionally if there is lipemia or icterus, there can be erroneous in the clot detection. So, Dr. Abhijit, can you let's discuss these issues one by one. So, why do you think occurs in the ward?
Sir, can you repeat again, sir?
So why do you think inadequate mixing or excess mixing or hemolysis can occur in a ward sample?
Sir, if you vigorously mix it, then there can be hemolysis.
Okay.
Then
And
suppose
if you don't
platelet factor
mix well,
can be activated.
there can be microclot formation or
Yes.
proper clot formation may occur. So why do you think these things can happen in a ward?
Mostly because of the innate expert is those who are doing, they are not properly doing in proper technique, or they are not properly trained, the internists or the nursing staff.
So you will be surprised to know that unfortunately these things are not because proper training, but these things occur because of uh, lack of attention being given at that time, or being in a lot of hurry at that time. So they just collect the sample, keep it there, do not mix it, or just in a hurry they just mix all the samples very vigorously. So, Dr. You would have taken samples in your maybe internship or otherwise. So, uh, can you just tell me how do you mix a sample after collecting it from the patient?
8 to 10 times, sir, we rotate the sample in
Okay,
inversion 8 to 10 times.
10 times.
Sir,
How many times how do you mix the sample?
sir, 4 to 8 times we inverse the sample. 4 to
Yeah,
8 times.
so usually 4 to 5 times you just invert the samples like this movement and do it slowly. It's not like very frequently done, or never do this kind of a motion for the sample. So simply just rotate the sample 4 to 5 times. That is enough for adequate mixing of the sample. Okay, so that avoids the formation of clots. And please do remember that clot formation occurs very quickly in the sample which are not mixed at the time of collection. So when you have collected the sample, then and there mixing is to be done. It's not like you have collected a sample from the cubicle or of the ward and start mixing the sample after collecting, let's say, samples from 5 or 6 patients. Okay, so after collection of the sample from the patient, mix then and there. So this becomes an important aspect whenever you are dealing with the uh, sample handling issues. Okay, uh, we come back to Dr. Supriya. So time and transport is a very, 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 very important thing. Okay, especially timing is most important in the coagulation lab. Always remember this thing, that timing is very important in a coagulation lab. there's some kind of recommendation that a patient sample can be processed within these times, but as a dictum, try to process all these samples as early as possible. Okay. So PT, although it is written that can be stable at 24 hours, should try to process it within 4 to 5 hours. I think this is wrongly mentioned. Similarly, for APDT, 4 to 6 hours. The samples are never to be refrigerated. Okay. Why, Dr. Neha, let's elaborate on these points. I think what I do is, so yeah, just a second. So Dr. Neha, why do you think these points are important for time and transport? What happens if the timing is delayed or the transport is not done in a proper way?
So we can get a falsely abnormal coagulation result.
Why?
That, so maybe there is loss of various factors.
Yes. One.
Yes, sir.
So, Dr. Marina, which factor has the shortest half-life?
Sir, factor 5 and factor 8.
So they get consumed during the clot formation, but which has the shortest half-life?
Factor 7.
So factor 7 has the shortest half-life. So any guesses about how much time?
So 4 to 6 hours.
So yeah, somewhere around that. So if your sample is getting processed after this much time, factor 7 will degrade very fast. If there is any kind of minor clot formation in it, the factor 8 and factor 5 will be consumed early in that. In all these scenarios, any kind of clotting activation which occurs, factor 7, factor 5, factor 8, they will be consumed at a very early rate. Okay, so what happens if factor 7 is low? If it is consumed?
Prolongation of PT is
Very good. And what happens if factor 8 is consumed?
APTT will be high, sir.
So these are your very early thing which occurs. Can you guess any scenarios where such delays can occur in the transport? Guess.
Transportation delay. The remote collection in periphery.
Yes. So that is the most common scenario, Dr. Marina. So you're working in Dibrugarh, right?
Yes, sir.
So think of a city which is, let's say, 50 kilometers from your area. Okay, think of a village which is around 50 or 60 kilometers from your medical college, or maybe let's say 100 kilometers from your medical college, where the sample is being collected and sent to your lab. Most of the time it comes in around a couple of hours, but on that particular day it took around 6 hours. So what can you do for such a thing? Can you do anything to rectify this thing?
Sir, transport should be done in and maintaining the temperature.
Okay.
If they maintain the temperature, then
so transport can be done while the temperature is to be done. Yes, the sample is not to be refrigerated. So this is very clear. The samples are to be transported timely and processed as early as possible. This is very frequent. This kind of error is very frequently seen in referral labs. Let's say for the large private pathology labs like, let's say, Lal's or Agilus or others, who collect samples from all different places and there is a central lab which processes those samples. In such a scenario, this is a common error which can occur. And not only PT, APDT, they are not representative. What happens is in such a scenario, you can have patients being mislabeled as a deficiency of different clotting factors.
Yes.
Okay.
Yes, sir.
So this is a very unfortunate thing, kind of thing which occurs. So usually what you should do is, if possible, try to collect the samples in your lab or in your hospital area only. Sometimes, many a time, sometimes what can happen is, even in your ward settings, the patient samples might have been collected, let's say on the previous night, or when the patient came to emergency, the samples were collected and are being sent to the coagulation lab next day morning. In such a scenario, also you can have that is also a plausible scenario where your samples will not be very representative of these things. Okay.
Yes, sir.
So, Dr. Abhijit, can you summarize this slide for me? Just go through the slide for me. Dr. Abhijit? Hi, Abhijit.
Hello, sir.
Hi,
Yes,
can
sir.
you go through the slide with me?
Yes, sir. So the errors, what happens is like in the underfilled tube, the PT will be high, APTT will also be high, and the INR will be high. D-dimer is not recordable, and heparin, in heparin contamination, it can be either high or low. But in APTT, heparin contamination will be more. And INR will be also either high or low. In high hematocrit, PT will be more, APTT will also be more, and INR will also be more. If the sample is delayed in processing, the PT will be either high or low, but APTT will always be high, and INR will be in the moderate range. Suppose there is residual platelets, then PT and INR and DI dimer cannot be calculated, but APTT will be low.
Sure. So we understand about all of these pre-analytical variables and how they are interfering with your coagulation lab results, especially PT and APTT. Heparin contamination, we also went through various scenarios where underfilling of the tube might be there, where the patient can have high hematocrit, like the newborns, high altitude, patient with cyanotic heart diseases. We understood the scenarios where patient can have heparin contamination, like your ICU setting when the patients are on central lines. Sometimes patients who are on therapeutic doses of anticoagulation, those can be the scenarios. Delay in processing when the samples have been kept in the ward and sent late to the lab. When the samples are collected in the periphery and sent to a central lab, those kind of the scenario where delay in processing can occur. Lastly, all of you just remember that no, these are the scenarios where your lab should be ready to reject that sample. Okay. One obvious thing is improper labeling, where you're not sure about the identity of the patient. And all the other things are like absolute contraindication. So if there is a clot formation in the sample, kindly reject it. Your sample is not fit to be analyzed. Your machine might get blocked. So that sample is to be rejected. If there is underfilling of the tube, that will lead to excess of citrate in the sample. Okay, relative excess of citrate, your coagulation result will be not evaluable in such a scenario. If there is severe hemolysis, your analyzer will not be able to see the clot formation. The optometry will not be great, and it will interfere with the test results. And lastly, like we discussed, if there is excess of delay, your clotting factor might be consumed in that time, and the sample again will not be very representative in such a scenario. What are the various clinical consequences? So first and foremost is you can give a wrong diagnosis for your patient, like especially in scenarios when the patient have let's say, very much delay in the sample processing, and the factor VIII has been consumed largely, and that patient, factor VIII might come out to very low. In such a scenario, you might label that patient as hemophilia. So those scenarios have occurred. Secondly, more often than not, PT is prolonged in warfarin patients. So if you give a wrong INR value, the patient dose adjustment for warfarin will be wrongly done. Anyways, in the hospital patients, if there is prolongation of PT or APDT being signed off wrongly, the patient might be given transfusions, especially FFP or cryo or even vitamin K for that matter. So this happens very often. Uh, you know, heparin contamination leading to prolonged APTT, sometimes prolonged PT, and in the ICU setting, the patient is sick. So, very often these patients are transfused with FFP for no great reason. You might miss a bleeding disorder, or you might overdiagnose a bleeding disorder. And sometimes, let's say when APDT is prolonged, there can be misdiagnosis or falsely labeling the patient as a thrombophilia, like positive for Apler syndrome or lupus anticoagulant. So those kind of scenarios can occur as a clinical consequence of a false report, which can occur for various reasons, or a wrong report which can occur for various reasons because of pre-analytical variables. Okay. Yeah. So I think that should be it from my part. Hi. So we are open for discussion. I think Dr. Sakshi and the organizing can help me with that.
Yes, sir. So there is a question in the chat box. So somebody is asking what is this plus or minus means in the either more or less. In the chart we showed na PT, APTT prolongation.
So plus or minus means that that just means that that value can be increased or normal at times.
Yes.
Okay. So plus minus basically means that it was used for PT, I think, if I remember correctly. That just means
Yes,
that
yes.
with heparin, the value of earliest thing to rise is APTT. If there is minor contamination, APTT goes up. For PT, rise can occur if there is a major heparin contamination in that sample.
Somebody is asking residual platelet means.
So I think that is with the processing part. Madam, you can expand on that. I think, yeah.
So when the centrifugation is not done at the correct speed, so there is in your plasma, there can be a little bit of platelets still into the plasma. So that means that can interfere with your tissue factor will be released, and that is how it interferes with the APTT and PT. Sir, if you allow, I would like to invite Dr. Ruchi and Kunal Sehgal sir also for
Yeah, sure.
their
Definitely.
further discussion. Yes.
So I can see in the chat
Ruchi,
box
yes, sir.
various
Ruchi ma'am. Yes, sir.
various participants have written about different conditions where hemoglobin is high.
Yes, sir.
They've written about a central line being drawn, various wards where, all those things which we discuss, chemotherapy
Yes, sir.
patients. So
Yes.
that was good.
Yes, sir.
Nice interactive session has happened. So, hello,
Yes,
ma'am.
sir.
Please.
Good evening, Dr. Mukul. Congratulations. It was interesting to hear from the clinical perspective, a clinical hematologist talking about the pre-analytical variables, because that is a major chunk, 60 to 70%. That's what literature says, that is where the major things go wrong. And as you said, that has clinical implications. And at a very short notice, you have given a very good overview of what all can go wrong. And just wanted to say that there are certain tests which people like you had asked when it should not be done. So like lupus should not be ever done in the acute phase, lupus anticoagulant. There are other alternative ELISA based other proteins which can be detected, like your anti-cardiolipin or beta 2 GP1, those can be done. Similarly, certain thrombophilia tests are also not indicated to be done during the acute phase, because these are all acute phase reactants. They all go up and will give false positive or a false negative, erroneous results can come. And if you are planning to do a test, wean off, as correctly said to you, wean off the patients from the anticoagulants, whatever they are there on it. And a major problem which happens is in the wards is that people don't, even if they have been provided with these evacuated test tubes, vacuotainers, the nursing staff is in habit of decapping it, and then with the needle and syringe collect it and then push it into the vacuotainer and then recap it. A very easy way for it to be picked up is just pick up the vial, the vacuotainer, and see whether the cap has a piercing or a hole in it and there is blood over it. That tells you that the sample has been collected directly through the evacuated system into the vacuotainers, because that is what we find majorly in our lab, that they are not collecting it directly and they are opening the tubes and then pushing the blood into it. Nowadays we have certain instruments which can lipemia and icterus is not a absolute contraindication, but yes, hemolysis and clots are mislabeling. All these are all absolute indications for rejecting the sample, patient sample. We have mechanical systems now, these machines are there. So lipemia and icterus are not much of a problem nowadays. In certain automated coagulation machines are there. And another thing, a lot of people were asking, like how to transport the samples, the citrated samples. If you are not able to send it to the lab within, say, 1 to 3 hours, the best way is to centrifuge it, and centrifuge it so that you prepare a platelet poor plasma, because platelets are a very rich source to act for where the granules which are there in the platelets, whereas and the membrane which contains phospholipid, they are a very potent activator of the coagulation cascade. So that will lead to consumption, and prolonged false PT and APTT will be there. So the best way is to centrifuge, prepare, do a single centrifugation or a double centrifugation, and prepare a platelet poor plasma. Platelet poor plasma is defined as plasma which contains less than 10,000 platelets, and then transport it in an ice or ice box or over wherever in a cold box, and then these samples are quite stable. Like in our labs which have not much of a volume, then they can even be stored at -20 degree for a month and at -80 degree for nearly more than a year. We have seen it, that sample remains stable. Another thing I just wanted to say, that most of the labs now have pneumatic tube systems. From the phlebotomy area, they are sent through the pneumatic tubes to the lab. Ideally, it does not affect this most of the coagulation tests, but platelet function tests, the aggregometry and all these are affected by it. So what we do is we call the patients to the lab. Best time is to call the patient to the lab and then collect it. And very rightly pointed out by you that history is the most important parameter before doing any, starting off with any test. So history dictates what next you will do. And so once again, thank you, Dr. Mukul.
Good evening, Kunal sir. Sir, you are muted, sir.
Hi, Dr. Mukul, Dr. Ruchi. Thank you, Dr. Mukul, for a fantastic talk. I think in a short span of time, you have, really nicely elaborated all the factors. Just something from a private lab perspective, I would like to state and emphasize what Dr. Ruchi was also saying. So, a protocol we follow in a lab because we do some basic coagulation assays, but we outsource a lot of our coagulation assays we don't do. And commonly one challenge you might face in practice is when you get a thrombophilia profile, you have collected 2 or 3 citrates, and now the question is, as ma'am said, that you need to double spin your, double centrifuge and get your platelet poor plasma. As a lab, we follow a policy that please check your centrifuge, the speed, and actually evaluate and run your platelet once in a while. You'll be surprised that you're not getting platelet poor plasma. That's not uncommon. So that is something as part of your SOP you should have. Checking your centrifuge. All centrifuges are not the same. They have different rotors, different speeds. So those are technical things in a lab which one should be aware of. Second thing, if you send it to an outsourced lab, typically in a thrombophilia profile, you'll have 5 or 6 assays. What happens is, what I do in my lab is, if you have a citrate plasma, which is more than, say, after spinning 2 or 3 tubes, you've got around 2 ml of citrate plasma, for example. I will convert into 4 or 5 aliquots of 400 to 500 microliter each. Because the lab which you're going to send it to is not going to do the test out of all the tests at one go. These are generally batch tests. So protein C may happen on one day, protein S may happen on another day, factor 8 may happen on another day. So what we do is we make 4 or 5 aliquots. We put this into our freezer or a -20. Then our lab where we are outsourcing this test is requested to carry dry ice. Those aliquots are transferred in dry ice and they go back into the freezer from the dry ice into the lab which operates. That is when now they want to remove a test, they will thaw one alicot. Imagine you are send them only one transfer tube with all your 2 ml of citrate plasma. You are telling the outsourced lab to thaw it, then refreeze it, thaw it and refreeze it. This is what spoils the sample. So this is one pre-analytical variable. As a pathology lab owner or operator or in charge of a lab, you can start putting an SOP of how you're going to even outsource your samples. So it's not often, the machines are all automated and today are very good, but it's all these pre-analytical variables which create a big problem to any lab, and then overall the interpretation goes wrong. So this is just one thing which we do in our lab, wanted to add, which I think other points have been very beautifully highlighted. So thank you so much.
Thank you, Dr. Kunal. So it's important. Just remember that please don't refrigerate or put ice to a whole blood sample.
Yes, very
It's
true.
a very commonly done mistake, and it's not uncommon. Every once in a while, maybe every 2 months, 3 months, we have a patient who have been diagnosed outside as, let's say, hemophilia A and B both, factor 8 and 9 both were deficient. So all those kind of reports have come up. We understand that this is not going to happen for a patient. So all these samples are preferably if possible, uh, done at the samples are processed as early. The samples are collected either in the hospital again and then processing them, or the other way is do the processing as Dr. Kunal and Dr. Ruchi has said. So just remember. Yes, ma'am.
बस डॉक्टर कुणाल ने अभी बोला ना, once the sample is frozen like -20 or -80, very correctly said, aliquot them and then send it. Once it is thawed, and thawing is also done in a very controlled manner, 37-degree water bath, 5 minutes it has to be thawed. After that thawing that sample again, you gently mix it by inversions, and once it is thawed, you cannot refreeze it. You have to discard. If it is a waste or whatever, it has to be discarded. You cannot refreeze it and then use it next time when you are putting the thing. It's gone.
Yes, ma'am.
So, Dr. Kushi, there is a good question about testing for protein C as antithrombin and factor SS. So, it just appeared that you missed our last discussion when Dr. Ruchi was taking the class. In the last session, we discussed that all these protein samples, protein C as antithrombin, most of the times, almost 95 to 98 out of 100 times, these samples are not required. Okay, don't take these samples in the acute setting. Even in the patient of chronic setting, there are very few indications when these testings are required. So just remember that when all these tests are required for a patient, maybe when you have a family history of thrombosis or in a patient of already known inherited thrombophilia, then in those cases maybe you can do these tests. Otherwise, for most of the patient of unprovoked DVT or even provoked thrombosis, these testings are not required. For the factor assay storage, maybe ma'am, you can expand again. So there is this question about how long plasma for testing factor assay can be stored.
Like I told you, it can be like after centrifugation and preparing a platelet poor plasma, you can store it at minus 20 or minus 80. Like we also do the special test, coagulation test on fixed days of the week. It's not done every day because the reagents are quite expensive, and once they are opened, they have a very short life. You have to use most, like for factor 8 assay, that reagent is only stable for 24 hours. So if you prepare a platelet poor plasma and then store it at minus 20 for 4 weeks, it is good. And for longer period, yes, at minus 70, but 70 or 80 degree for a longer period. Only thing is that, the correct temperature is there. What it is showing, it is actually minus 80 and actually minus 20. Just like Dr. Kunal said, that what your centrifuge is giving the speed, you should always be maintaining and charting the temperature. Otherwise, for that period, it can stay. And proper thawing and immediately putting it for testing. That is the thing.
Ma'am, I would also like to ask just what is the practice of calculating MNPT and MNAPTT? Like how frequently it should be calculated?
MNPT ideally should be tested on minimum 20. If it is more than 20, okay. Equal number of males, equal number of females. We try to avoid any like pregnant females in it or any known case. They should be normal. Otherwise, so individually we test them and then we calculate from that the MNPT, and ideally it should be done at least once a year. Ideally, it should be done once a year.
Yes, maybe whenever the batch is changed, if some
Yes,
lot is.
but that is very frequent. So because most of the time these lab technicians, the residents, they are the people who donate. So that frequently we don't do it. But yes, theoretically that is with each batch you should recalculate your MNPT.
Right.
Ma'am, for a let's say a reference lab or an NABL lab, will you still recommend it testing once in a year, or
No.
such a thing are to be documented always?
Yes, that's why what they said, that with each batch it should be done. Yes.
Many labs pool the plasma when they are collecting it, and
Yeah.
then they multiple aliquots and they freeze this. So what has happened is for MNPT calculation of different batch, your pooled plasma is ready and aliquoted at minus 80. So that is also useful. So big reference lab often do these kind of tricks to sort of overcome this problem over a period of time.
Yes.
But again, your procedure has to be very perfect. We also used to do that, but
it is challenging.
Yes,
it is challenging.
2 3 times it was not platelet poor, so the entire batch had to be discarded. So now that's what we are yet not NABL, so we are getting away with it. But once we also go in for accreditation, then we will have to do it with each change of batch.
Somebody asked, but sir has already replied. Can we you do MNPT using FFP?
Big no. Don't bypass the SOPs or that.
Yes. Yes, sir.
Okay, so I think no further questions. Ma'am, anything, or Dr. Kunal, anything you want to ask?
Thank you
or
so
say?
much. That was a nice interaction. Thank you.
Thank you.
Thank you so much.